Thank you. My first talk is about the role of IL-1 blockers in autoinflammatory diseases. How do I? I'm pushing the button, but it doesn't work. Yeah, the green one. Oh, thank you. So, okay, this is just a picture of my hospital. Okay, so this is the outline of my talk. I will touch briefly on autoinflammatory diseases, and then on the mechanism of IL-1 blockers, and then on the evidence for the efficacy and safety of IL-1 blockers in hereditary periodic fevers, and a little bit about IL-1 blockers in special populations of FMF and complications of FMF like amyloidosis, and kidney transplanted patients, and then about some miscellaneous. So autoinflammatory disorders are a group of disorders with symptoms of recurrent episodes of fever. Sometimes it can be accompanied by different symptoms like rash, serositis, like pleuritis or peritonitis, arthritis, sometimes meningitis, and uveitis. In contrast to autoimmune diseases, autoinflammatory diseases does not have autoantibodies, since these are diseases of the innate immune system and not the adaptive immune system. And usually inflammatory markers like CRP and DSR are elevated during the disease flares, and they also may remain abnormal in between the episodes of acute attacks, and this may lead to the most dreadful complication of autoinflammatory diseases, which is secondary AA amyloidosis after long-standing chronic inflammation. So this is just a picture of just an example of the 5 maybe most common autoinflammatory diseases that we encounter, like PFAPA, CAPS, FMF, which we have a lot in Israel, TRAPS, tumor necrosis factor receptor associated periodic syndrome, and MKD or hyper IgD syndrome. And all of them in their criteria for diagnosis have, of course, fever and other characteristics, which each disease has some different characteristics and phenotype. So what are the IL-1 blockers that we have now on the market for autoinflammatory diseases? So we have anakinra, rilonacept, and canakinumab, and I will go over the mechanism of action. So anakinra is a recombinant protein. It's a receptor antagonist of the IL-1 receptor, and as can be seen here in the cartoon, on the left you see normal IL-1 beta signaling with IL-1 beta attaching to its receptor and signaling further down inflammation. And you can see the anakinra in the blue, which blocks the receptor and then blocking the IL-1 beta from attaching to its receptor and causing inflammation. The half-life of anakinra is short, and it is given as a subcutaneous injection every day. Rilonacept is another drug which was not approved in Europe, and actually is pretty expensive and rarely used worldwide. But it's a fusion protein of the IL-1 beta receptor attached to a human IgG molecule, and as can be seen in the cartoon, it attaches to the IL-1 alpha and IL-1 beta subunit, and it attaches in the serum, and then it prevents it from blocking or attaching to the receptor, to the IL-1 receptor. The half-life is moderate, and it is given as a subcutaneous injection every week. Canakinumab is a fully human IgG1 anti-IL-1 beta monoclonal antibody, and as can be seen here, it neutralizes, it catches the IL-1 beta in the plasma. Its half-life is long, and it is given as a subcutaneous injection every 4 weeks usually. So I will go over some evidence for the efficacy and safety of these drugs, and mainly on randomized controlled trials that were published. And the first one is canakinumab, which was published in 2018. in the New England Journal of Medicine. This study is called the cluster study, and the design was a phase 3 randomized double-blind placebo-controlled study. And the objective of the study was to assess the efficacy and safety of canakinumab in patients with 3 autoinflammatory diseases, mainly FMF, MKD, and TRAPS. So this is the design of the study. In this publication, it was the first epoch, so it was the first 16 weeks of the study. And as we can see, in this phase, the patients received placebo every 4 weeks or canakinumab every 4 weeks, 150 milligrams for 16 weeks. The primary outcome was no new disease flares over 16 weeks of treatment, and the resolution of the index flare. All patients entered the study when they had a flare and started getting canakinumab when they had a flare. And another primary outcome was the resolution of this index flare by day 15. And they had secondary outcomes of patient global assessment, lower than 2, and low levels of CRP and SAA. So these are the baseline characteristics of the patient. It is not really important to go over all the details. There were no differences between the groups. What we can see here that for FMF patients, they had approximately 30 patients in each group. For MKD, it was 37 in the canakinumab and 35 in the placebo. And for TRAPS, it was 22 in the canakinumab and 24 in the placebo group. So these are the results, and in the upper part of the slide you can see the primary outcome, and the orange bar are the canakinumab treated patients and the blue bars are the placebo. And as can be seen here, the resolution of the baseline flare in patients receiving canakinumab was much better than patients receiving placebo, and this is true for the whole 3 diseases, all these autoinflammatory diseases, and this was statistically significant. Also, complete response after 16 weeks without another attack. Again, we can see the orange bars, and there is a big difference between the placebo and the canakinumab showing its efficacy. If we look at secondary outcomes on the bottom part of the slide, we can see the PGA and CRP and SAA levels for these 3 diseases. Again, the orange bars are the canakinumab, and we can see that the canakinumab group had a very big different effect from the placebo group. They also tried in this study for patients who did not respond very well or did not respond completely to increase the dose of canakinumab to 300 milligram every 4 weeks. And as can be seen in this slide with the light blue bars, there was further increase in the efficacy of canakinumab with a higher dose, and this is true for all 3 diseases. If we look at adverse events of canakinumab, so to summarize this busy slide, there were no signal of adverse events between canakinumab and placebo in all 3 diseases. Nothing was significant. So the summary of this study showed the superiority of canakinumab compared with placebo, the fast onset of response, and efficacious control of clinical signs and symptoms. And also canakinumab was safe and well tolerated. This is another interesting study that I brought just to show the long-term beneficial effect of canakinumab in FMF. These are all colchicine-resistant FMF patients, and this was done for 12 months. And as we can see, the longer you give canakinumab, the better the outcome in all aspects that they studied, the fever attacks, the joint involvement, the GI attacks, the myalgias, the serositis. And on the bottom right, you can see exertional leg pain, which is another manifestation of FMF, which is not so well responding to canakinumab. It is responding, but you can see that here there is no effect of the length of the treatment, and it stays fixed through the whole year. The only randomized controlled trial that was published for anakinra was published by our group in 2017, and it was a double-blinded placebo-controlled trial. We recruited adult colchicine-resistant FMF patients with 2 MEFV mutations who were receiving their maximal dose of colchicine, usually 2 milligrams per day, and even better, even more sometimes. and they were yet suffering from at least one attack per month. This is our definition of patients who are colchicine resistant. All patients received anakinra, subcutaneous every day, or placebo, and all patients were treated, continued treatment with colchicine, and the period of the study was 4 months. So this is the screening algorithm, and as you can see, eventually we had a small cohort of 12 patients on anakinra and 13 patients on placebo. And these are the genotypes of the patients, and not surprisingly, if you know FMF, you know that the M694V mutation is the most severe mutation with a more severe phenotype. So most patients were homozygous to the M694V mutation. These are the patients that do not respond well to colchicine. And these are the baseline characteristics of the patients, and you can see that there was no difference between the patients in the anakinra and the placebo group. And we can see that the number of attacks per patient per month was approximately 5 in each group, in the anakinra group and in the placebo group. And the primary outcome was the number of attacks per patient per month, and we see that it decreased with anakinra to 1.6 compared to 5, and it also decreased with placebo to 3.5, but the difference between anakinra and placebo was statistically significant. And if we look at secondary outcome, like attacks in any site, or abdominal attacks, or joint attacks, or skin attacks, or CRP and SAA level and quality of life, we can see that in all parameters on anakinra, they got better, the patients got better. Some reached statistical significance, some did not, but probably because of the very small cohort of this study. In terms of safety, we didn't see any signal of safety with anakinra versus placebo. And we concluded that anakinra is effective and safe for colchicine refractory FMF patients. The third drug that I mentioned is rilonacept. And there was only one small trial, controlled double-blind randomized trial. They had 14 patients, age 4 and up. It was an adult population and pediatric population combined. And the results showed that rilonacept decreased the attack risk ratio by 40% to 0.59. And the median number of attacks per month was 0.77 with rilonacept versus 2 with placebo. And in this study, they showed that injection site reactions were more frequent, significantly more frequent with rilonacept. Another interesting aspect for FMF patients is what happens when they have amyloidosis. Can we still treat them with anti-IL-1 blockers? And is there an effect of anti-IL-1 blockers on patients who already have the most severe complication of FMF, amyloidosis? So this is a nice study. They had 16 patients, and we can see their parameters before IL-1 antagonist and after IL-1 antagonist. All patients, of course, had FMF and AA amyloidosis, and we can see that IL-1 antagonists decreased their acute phase reactants, their ESR, their CRP, also decreased their urinary protein excretion from 1.6 gram to 0.5 grams a day, and was very effective, and they didn't see any side effect in this population of anti-IL-1. Another interesting population is the patients who have kidney transplantation because of AA amyloidosis, because of FMF. Is it safe to give canakinumab? Is it effective? Is there too much immunosuppression because they get immunosuppressing drugs with after kidney transplantation? So we can see this study, they had 9 patients. It was a small study. Most patients had amyloidosis, recurrent amyloidosis in their transplanted kidney. And as we can see after the start of canakinumab on the far right, none of the patients had any more attacks of FMF as compared to before canakinumab. And as we can see here, their mean CRP decreased significantly after canakinumab. Their creatinine clearance increased a little bit after canakinumab, and the 24 hours proteinuria decreased from more than 2 grams a day to 700 milligrams per day. So it was very effective in kidney transplanted patients, and again, they saw no safety signal in this study. Okay, another rare but important phenomenon of FMF or attack of FMF and of other autoinflammatory diseases, not only FMF, is recurrent pericarditis. You all probably know patients who have idiopathic recurrent pericarditis. They need a lot of steroids, and their disease flares a lot of the times. So this is an editorial which was recently published last month from the Journal of the American College of Cardiology about the effect of IL-1 blockers on recurrent pericarditis. And they summarized 3 studies of IL-1 blockers in patients with recurrent pericarditis: anakinra in one study, rilonacept in another, and goflikicept, which is a new IL-1 blocker in patients with recurrent pericarditis. As we can see, this is the number of flares, the percentage of patients who has flares. This is the graph, and we can see the placebo in blue and the anti-IL-1 blockers in red, and we can see that it was very, very effective for recurrent pericarditis. And the last thing is another rare manifestation of FMF, which is called protracted febrile myalgia. In this attack, the patients suffer from diffuse myalgia with fever and with high levels of acute phase reactants, and they actually have inflammation in their muscles, although CPK is normal. And we don't have good treatment for that. Colchicine does not prevent it. We don't have any other good drug for that syndrome when it happens, and we give steroid. We usually give steroids, prednisone, high doses of prednisone, and this is protracted, meaning it is lasting for a long time, and the patient get a cumulative dose of steroids, which is very high eventually. So in this case report, they described 2 cases of protracted febrile myalgia, which were treated with IL-1 blocker, this time with anakinra. And they report that after getting IL-1 blocker, getting anakinra, their muscle pain and inflammation, as can be seen in this MRI here that they published, resolved completely and very quickly. And it had a very good steroid-sparing effect and was very effective. So this looks like a very effective treatment for this rare syndrome. So in conclusion, IL-1 blockade is efficacious and safe across a variety of hereditary periodic fever syndrome. It is also efficacious to control chronic inflammation in periodic fever syndrome and probably prevent amyloidosis. It is also safe and efficacious in patients who already have amyloidosis from their periodic fever syndrome, and it is also effective in recurrent pericarditis and probably other rare manifestations of autoinflammatory diseases. Thank you.